So in this section, we'll be covering some details about the hormones secreted from the posterior pituitary. So in this slide, as you will see, it's a schematic of the pituitary gland. And if you recall from embryology, the pituitary gland is actually derived from two parts. The posterior lobe is actually formed and developed from the third ventricle, which remains connected to the hypothalamus. And the anterior lobe is developing from a structure called the Rathke's pouch, which is part of the embryonic oral ectoderm and ultimately fuses with the posterior lobe. The whole pituitary gland itself is sitting in a bony structure called the sella turcica. So in this section, as I mentioned, we will cover the two posterior pituitary hormones, vasopressin or ADH, anterior diuretic hormone, and oxytocin. So first one is the actions of ADH or vasopressin. So ADH is the hormone that's mainly involved with the regulation of water balance. So it's called antidiuretic hormone, as its primary function or action rather is in the kidney, where it works on V2 receptors in the distal kidney tubule to absorb water, and therefore the action is to increase water absorption. In the left panel of this slide is a schematic showing urine that is dilute, and the right panel is the schematic showing urine that's very concentrated. So as you can see, the urine osms there is 1200. So and the reason for the urine osms to be 1200 is because of the actions of ADH. So ADH is antidiuretic, meaning that it prevents the diuresis and helps absorb water. And so the end result is a urine that's highly concentrated. So ADH is actually available for clinical use as desmopressin or DDAVP. And DDAVP is used to actually mimic the antidiuretic effects of ADH in patients with something called central diabetes insipidus. And we'll cover this in the next several slides. ADH is also called vasopressin, as I mentioned earlier, because of its actions besides the kidney, also in the vasculature. So instead of acting on the V2 receptors, which is a major receptors in the kidney, there are V1 receptors that are specifically located on the vasculature. And hence, the action of ADH and binding of the ADH to V1 results in vasoconstriction, and hence the name vasopressin. It promotes release of von Willebrand factor and factor 8 from the endothelium, all of which will then contribute to vasoconstriction. But for our purposes here, we will be focusing mostly on the action of ADH in the kidney, which is its major physiological action. In the next slide is illustrated the conditions where there is a dysregulation of the hormone. So as in most of endocrinology, there is either too much or too little of the hormone. And when there's too little, it leads to a condition called diabetes insipidus. And then when there's too much, it leads to a condition called SIADH. So let's consider first the situation where there's ADH deficiency or diabetes insipidus. There could be two reasons for diabetes insipidus, depending on whether the problem lies in the production or in the response. So an ADH production defect or an ADH response defect. If it's a production defect, that usually refers to the problem where the gland itself is perturbed, the gland itself is not able to produce the hormone, and hence you have a decrease in the hormone itself. And for that reason, this particular defect is called central diabetes insipidus, central referring to the source, which is the posterior pituitary itself. And some common reasons for this type of defect could be brain trauma, craniopharyngioma, which is a tumor. It could be an infiltration. So anything that damages the posterior pituitary could ultimately lead to a production defect. And in contrast, a defect that is primarily in the kidney, because that is the responsive organ, leads to a disease called nephrogenic diabetes insipidus. And nephrogenic, of course, referring to the end organ, which is the kidney, where there is plenty of ADH, but the ADH is not able to somehow bind to the V2 receptor, either because of a mutation in the receptor or any other defect that is happening at the receptor level, that is then therefore called nephrogenic DI. So one way to distinguish between whether it's central or nephrogenic is the actual response to ADH. So people who have central DI, when given ADH, would really respond nicely to the administration of ADH because the problem lies in the production. Whereas those people who have a defect in the kidney or a response defect will not respond to exogenous ADH. So if you give these patients ADH, their DI will continue on. In other words, they will continue to have a dilute urine despite the administration of ADH. So that's one way to distinguish between central versus nephrogenic. Now moving on to the other end of the spectrum, where there's too much ADH, and that is a syndrome called inappropriate ADH or SIADH. And excess ADH can be caused by a lot of different factors, and one of the more common ones, at least from the board perspective, is a syndrome called paraneoplastic syndrome, referring to a syndrome where a tumor, a good example of that would be a lung tumor, specifically small cell carcinoma of the lung, that would be producing ADH in excess. And that process is called the paraneoplastic process, where a lung tumor is actually producing ADH, and then that results in SIADH. Other common conditions could be just drugs of various kinds, or other CNS injuries like a stroke or a head injury. So any of those things could result in a high ADH. One way to separate out or at least help in the diagnosis of SIADH could be to look at the urine osm to the plasma osm ratios. So typically, to make the diagnosis of SIADH, the urine osms would be higher than the plasma osms. And another clinical clue is to look at the urine sodium, which usually turns out to be greater than 20. And the reason for this is because, again, if you think about too much ADH, it's helping retain all of this excess water, and therefore free water is being retained, diluting the plasma more so than the urine, and hence the urine osm is actually more concentrated than the plasma osm. In this particular case, the treatment would simply be to water restrict, which is the most common and the most effective treatment. And in more severe cases, and when that's not working, administration of hypertonic saline may have to be necessary, and in some cases we may have to even use demeclocycline, which is a tetracycline analog, which is essentially an ADH poison, and therefore inhibits the action of ADH in the kidney. So again, water restriction is the most common and oftentimes is enough to correct this, and in very severe cases, hypertonic saline may be necessary or demeclocycline may be necessary. And just to summarize in terms of the treatment for diabetes insipidus, the treatment really depends on the cause of the DI. So if it's central DI, the treatment is simply replenishing the hormone, which is to give back the ADH, and we do that by DDAVP. And in the case of nephrogenic DI, obviously you're not going to use ADH because that's not going to really help. And in these situations, we end up using hydrochlorothiazide as a sort of a palliative therapy because there's really no good therapy for nephrogenic DI. So let's try to put these concepts to some practical use by doing some illustrative questions. So question 2 is dealing with a patient who has the following serum osms, urine osms, and the urine sodium that's been listed. And the question is asking which of the following sets of values is most likely obtained from a patient having inappropriate ADH. In other words, the SIADH picture. So they would want us to diagnose by looking at just these values who has SIADH. So is it, A through F, which is the right answer? So the way to approach these types of questions would be to actually try to understand some basic concepts about SIADH that we talked about. So the first thing that we talked about was to look at the urine and the plasma osms. So by definition, when you have too much ADH, you're diluting your plasma. So your plasma osms are going to be lower than the urine osms. So look for a situation where the urine osms is higher. So clearly A and C are not appropriate because they have low urine osms. And those would in fact be a situation for DI. So B, D, E, and F could be possibilities. But again, you're looking for a situation where the urine osm is greater than the plasma osm. And in this particular case, the ones that would come as being possible answers would be either B or D. Then what you want to look for is the second pearl of information for SIADH, which is the urine sodium. So the urine sodium is usually greater than 20 because they're inappropriately wasting sodium as well. And in this case, if you're comparing B versus D, you can clearly see that B is a situation where the urine sodium is 60. And so that would be, in essence, the most consistent picture for SIADH. So in this case, the answer is B, which shows that in a situation of SIADH, you have a urine osm, which is 550, which is greater than 270, which is the plasma osm, and then the urine sodium is greater than 20, and in this case, it's 60. So let's do another question that highlights the issue of water balance and the hormonal regulation associated with it. So this question is showing a graph depicting urine over plasma osmolarity in the y-axis and the urinary flow rate in the x-axis in a healthy human subject. The question is, which of the following most likely produce the change from x to y? In other words, what's causing the change from a low flow rate to a high flow rate, and also what's causing the change from a high urine over plasma osm to a low urine over plasma osm ratio. So let's consider each of these one at a time. Let's start at the bottom. So if you inject ADH, which is antidiuretic hormone, by definition, that would raise the concentration of the plasma because it's antidiuretic. I'm sorry, it would raise the concentration of the urine because it's antidiuretic hormone, and so it would make the urine osms fairly concentrated. So it's unlikely that you would be producing dilute urine, nor would you be producing a high urine flow rate. So that is not the right answer for this question. Oral ingestion of a 3% solution of saline is essentially ingesting a hypertonic saline solution, which again would raise the urine concentration or urine osms, and so unlikely to be producing a situation where you're going from a high urine over plasma osm to a low urine over plasma osm. And in a similar situation, ingesting hypertonic glucose would result again in a situation where you're going and excreting out a concentrated urine as opposed to a dilute urine. Ingesting 0.9% saline, which is option B, is also unlikely to be the right answer because 0.9% saline is isotonic. So it shouldn't really change the urine or the plasma osms that dramatically, where you're going from a very high urine over plasma ratio to a low urine over plasma ratio. So it's unlikely to be the answer in this situation. So the only one that really makes sense is the choice number A, which is the oral ingestion of just free water. So in this case, if you're ingesting just free water, the kidney is not able to handle that amount of water load because it's a free water load which has to be excreted out, and so it does that by producing a pretty dilute urine and at a high flow rate, so homeostasis is maintained, and as a result of that water ingestion you're producing a high amount of volume and at the same time resulting in a very dilute urine. So therefore a urine over plasma osms ratio would be lower, and hence you would be going from X to Y. And the final hormone in the posterior pituitary would be the hormone that we've already looked at. It's called oxytocin, and this is a hormone that's really important in childbirth or parturition because it is a hormone that is involved in the positive feedback loop for stimulating uterine contractions. Besides that result. It is also involved in the contraction of the myoepithelial cells in the breast, and is important during the suckling response of the infant. But the important point to remember about oxytocin is that it is a hormone that's involved with, again, positive feedback loop in both these situations. So this essentially concludes the posterior pituitary section. The take-home points here are the two hormones, vasopressin or ADH, and the second one is oxytocin. In regards to ADH, it's very important to realize that ADH is the main hormone regulating water balance, and defects in ADH, either too much or too little, can lead to disease. When there's too much ADH, you have a syndrome of SIADH, and when there's too little or ADH deficiency, it leads to a disease called diabetes insipidus, which can be either central or nephrogenic depending on the cause. Next section, we'll turn our attention to focusing on the hormones of the anterior